In this video, we discuss the use of sildenafil and other anti-PDE5 drugs during cancer treatment. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101. Quick tips to help you survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. Sildenafil, Viagra, has been approved for human use in the US and Europe since 1998 and is used by millions of people annually with very few negative side effects. Although initially studied for reducing angina and high blood pressure, sildenafil is FDA approved for the treatment of erectile dysfunction. It is available over the counter in the UK and Mexico, but is still a prescription in the US. Its main mechanism of action against cancer is primarily through PDE5 inhibition. PDE5 breaks down cGMP, a secondary messenger molecule that is a regulator of ion channel conductance, apoptosis, and blood flow vasodilation. PDE5 has been found to be overexpressed in many cancer types, including breast, prostate, lung, colorectal cancers, melanoma, and more. Sildenafil is also an aromatase inhibitor, an enzyme that prevents the conversion of testosterone into estrogen. Aromatase inhibitors are commonly used in breast cancer treatment. Aromatase has also been found to be overexpressed in glioblastoma, lung, and pancreas cancers. Many animal and cell line experiments have shown sildenafil's efficacy against cancer. The addition of sildenafil increased the cytotoxicity of the common cancer drug doxorubicin in 2 prostate cancer cell lines by 26% in the control with a higher concentration and 149% in the control with a lower concentration, then lowered tumor weight in a mouse model by 1/3rd. It increased the cytotoxicity of doxorubicin from 50% in a breast cancer line all the way up to 97% with the highest concentration of sildenafil. The same experiment showed that in mice implanted with a tumor from breast cancer cells, the tumor grew 570% with just treatment with doxorubicin, 400% with just treatment with sildenafil, but only 121% when treated with both doxorubicin and sildenafil. Sildenafil does not show signs of being able to kill cancer independently, but it does show strong signs of being able to stymie its growth and spread. PDE5 inhibitors have also been documented to improve microvascular permeability of the lymphoma drug rituximab. When the anti-PDE5 drug tadalafil was added to rituximab in mouse models of lymphoma, it prolonged survival 13%. Reporting of these animal trials could go on, as they are actually quite numerous. Cancer medications anti-PDE5 inhibitors have synergized with include celecoxib, fingolimod, fenretinide, all-trans-retinoic acid, cyclophosphamide, cisplatin, oxaliplatin, trastuzumab, 5-fluorouracil, anti-PD1, regorafenib, neratinib, and many more. One common thread in all of these studies is that the anti-PDE5 drug makes it easier for the medication to reach the tumor. It also synergizes quite well with the dietary supplement curcumin. Clinical trials in humans have shown that PDE5 inhibitors are safe in humans during cancer treatment. They have actually probably been used millions of times concurrently with cancer treatments outside of clinical trials, considering how interwoven PDE5 inhibitors have become into the fabric of everyday life. The first report of sildenafil's efficacy against cancer in humans came in 2004. 5 patients with Waldenstrom's macroglobulinemia, a rare form of lymphoma, were treated with sildenafil in addition to standard of care. Unexpectedly, one patient had a complete response, while 4 more had partial responses. Based on these incidental findings, another trial with 30 patients with slowly progressive Waldenstrom's macroglobulinemia who were also ineligible for other cancer therapies were treated with 100 milligrams per day of sildenafil. At 3 months, serum IgM levels, the key biomarker in Waldenstrom's macroglobulinemia, declined in 63% patients by around 18%, and 17% demonstrated a drop in IgM levels of 25% or more. Sildenafil concurrent with radiotherapy led to improved outcomes in 3 men with penile cancer. Another case report described a man who normalized his leukemia with sildenafil monotherapy. Another case report described a man with refractory multiple myeloma who had a 90% reduction in disease burden with the addition of tadalafil, another PDE5 inhibitor, into his regimen. He also had a reduction in myeloid-derived suppressor cells, key suppressors of immunity and restoration of T-cell function. Another human trial in head and neck cancer showed that tadalafil decreased myeloid-derived suppressor cells and suppressive Tregs, while upregulating the killer CD8+ cells, all without additional toxicities. Retrospective studies have indicated the efficacy of sildenafil during cancer treatment as well. Over a 4.25-year follow-up period, the mortality rate among male colorectal cancer patients who used PDE5 inhibitors was 20.20 each 1,000 person year, while the mortality rate for colorectal cancer patients who did not use PDE5 inhibitors was 37.87 each 1,000 person year. This effect was even more pronounced among patients who underwent surgery. The same study revealed men who were diagnosed with benign colorectal polyps and took PDE5 inhibitors had a 35% lower chance of developing colorectal cancer than those who did not. Higher PDE5 doses were associated with greater protection. Another retrospective study found that men who had used a PDE5 inhibitor had an 18% lower risk of developing colorectal cancer than those who didn't. Sildenafil, vitro, may actually be the anti-PDE5 drug with the strongest anti-cancer activity, but it has not been tested as much as sildenafil. For more information, please see the book Cancer Self-Defense 101, Quick Tips to Help You Survive.